يستخدموا البرودكاستنج للحضور في القاعة نفس محاضرات القاعة الرئيسية، أو يتوجهوا إلى الوركشوب اللي هي تكون موجودة برا للسيشن. اليوم الافتتاح بإذن الله تعالى يبدأ الساعة 8 وحيكون الاستقبال على الساعة 7:30. ماني حابة أخر. أشكركم جميعا لحضوركم، وطبعا نورت جدة، ونتمنى الجميع أنه يستمتع بالمؤتمر والفعاليات المصاحبة. كما رأيتم في الجدول، بالإضافة إلى الجدول الرئيسي للكبار، في طبعا البيدياتريك روماتولوجي بروجرام، وفي باراليل سيشن للروماتولوجي فور نون روماتولوجيست. at the same time في session for nursing. ومع المؤتمر بإذن الله آخر يوم حيكون في فعالية للمرضى والمجتمع على واجهة جدة البحرية. طبعا نتمنى من الجميع المشاركة. First session will be shared by Professor Sami Bahlas, all of you, and Dr. Fahad Al-Anizi. All of you know Prof. Sami. He's a professor from King Abdulaziz University, and he's very active in rheumatology, mashallah, and he's doing yearly an excellent rheumatology meeting that help the society and all rheumatology doctors. Prof. Sami has a lot of publication, and he's going to chair the first session. The second chairperson, Dr. Fahad Al-Anizi, most of you know him. He's a very active. He's the general Secretary General of the Society of Rheumatology, and since joining the society, he did a lot actually, and he's very active in all activity of the society. He's associate professor in Al-Majma'a University, and we'll start the session. Welcome, both of you.
Bismillah wa salatu wassalam ala Rasulillah. First, I would like to thank Saudi Society of Rheumatology for arranging this excellent meeting, excellent topics, excellent speakers, and excellent chairpersons also. I would like also to welcome all the delegates, كل الضيوف to Jeddah. I hope you enjoyed this meeting and you enjoy Jeddah. Our first session, inshallah, will be by Dr. Wafa Asweri, who is a consultant pediatric rheumatologist, King Abdulaziz Medical City, National Guard, Health Affairs in Riyadh, Saudi Arabia. She has fellowship in pediatric from the Royal College of Physicians, London, and she's Associate Dean of the College of Medicine in the female branch, and she is a member, College Council member, College of Medicine, King Saud bin Abdulaziz University for Health Sciences. She will talk to us about a very important topic that we face every day, which is transition of care from pediatric to adults. Doctora, تفضلي, the floor is yours.
السلام عليكم وكل عام وانتم بخير. Thank you very much. I would like to thank the Saudi Society for Rheumatology for this invitation, and thank you, Prof. Sami, for the very generous introduction. So I will not take time, and I will start with my presentation, which is talking and touching base of a very important practice point in the life of pediatric and adult rheumatologists, which is the transition process. I have no conflicts to disclose. So it has been now more than 35 years since the concept of transition appeared into the medical literature of rheumatology, with a gradual growth of evidence around this process. And there are more publications of specific guidance for policymakers and professionals. So what is transition? Transition is defined as a purposeful, planned movement of adolescents and young adults with a chronic physical and medical condition, regardless of the primary diagnosis, from a child-centered care to an adult-oriented healthcare systems. This is in contrary to the what we call it a transfer, which is a one-time event in which the patient is handed over from a child-centered care to an adult-based services. So basically, the transitional clinical care involves addressing evolving psychological aspects, educational and vocational aspects, in addition to the daily practice of physical and medical aspects of the clinical care. It is usually graduate, responsive, and it should be developmentally appropriate, and it requires engagement of both the child and adult care services, and it usually spans over the ages between 11 to 25 years. Since then, I would like to highlight a few landmarks in the transition journey of transition. The first evidence-based transition care program implemented in a multi-center controlled trial in the United Kingdom was published in 2006, and this is, they called it Growing Up and Moving On. And since then, it has been adopted as a good practice in the British Society of Rheumatology. After that, the guidance for primary and specialty care on practice-based transition supports using an age-based algorithm was published in 2011. This is in combination with the American Association of Pediatrics, family physician, and general physicians. And this is what they call it, the GOT transition program, that is based on the 6 core elements of healthcare transition. And this is now adopted in the American College of Rheumatology as the practice to be adopted for transition of adolescents and young adults to the adult care. Recently, the press group, they published their standards and recommendations for transitional care of young people with juvenile onset rheumatic diseases. So why transition is important in rheumatology? Because childhood onset rheumatic diseases now become an adult problems. Over the past 30 years and so, there is a great improvement in the medical care of pediatric rheumatology, with so many of our patients now are growing up with either a cure or very good control of their diseases, so they eventually end up in the adult care. In addition, it is still, the rheumatic diseases are recognized as rare disorders in the general healthcare practice of family medicine. Most of our diseases, actually, they might end up with serious, potentially life-threatening or life-limiting multi-system issues. This eventually will affect both disease and body disease control, body image, and it does usually involve multidisciplinary care specialties, with an overall burden, of course, on their lifelong expectancy. In addition to the nature of the diseases dealt with in pediatric age group, there are certain challenges for this age group, which is they are now focused on independence, self-advocacy, the effect of the peer relationship. There is a more focus on education and vocation, the development of sexual identity, and all these issues actually they become secondary to their lifestyle and whatever they are looking for during this age group. So a premature or uncontrolled or improper transfer and transition of such patients to the adult care service will eventually might end up with disengagement of those high-risk patients, and this will lead to self-management challenges and unstable medical care conditions, increased rate of treatment dropouts and non-adherence, eventually increase disease morbidity and might be mortality even, loss of school and education. Nonetheless, future risky behaviors and mental issues. So, talking about all this, what is the experience of transitional care across the globe in rheumatology? This has been looked at in Europe, where they have screened through a questionnaire 115 centers in 22 European countries with a response rate of 44%. They have responded that although 99% they have supported the and believe that there should be a systematic transition process transferring children to adult care, 74% had a form of a transitional service, 27 only percent they do have a written transition policy, and designated staff to support the transition care was only in a minority of centers, and only 36% they used a checklist to support the service. The CARA group from the state and Canada, they have also conducted a questionnaire from 25 questions for 288 members. 55% is the response rate, and only 8% of them, they have a formal written transition policy, whereas 42% they have informal approach, and 33% of them, they have available tools based on their institutional guidelines for healthcare transition and maintenance. And 30% they do have a designated team members as a transition coordinator. What are the major barriers from the Western countries is unmet educational and training needs among both pediatric and adult physicians. Pediatric staff, they do lack sufficient time to provide transition service. There is some form of a fragmentation of primary and specialty adult care. There is a kind of expected bonding between the adolescents, parents, and physician who provided a long-term care for those children as they grow up. And adolescents, usually they lack knowledge about their own condition and skills about self-advocacy. Pediatric staff, they lack even skills in initiating and planning a transition. And there is a lack of available adult specialist care for older adolescents and young adults with special needs. What about the Brazilian, which is considered as a developing country? They have used the same questionnaire that is being used with the CARA group, and they got 68% response from pediatric rheumatologists. 13% had a well-established transition program, and 83% they don't use any special tools, so they are using an informal transition process. And 61% has no designated person for coordination transition, whereas 38% is mainly done by pediatric rheumatologists. What is the major barrier being mentioned in this paper is the emotional attachment to patients is the major cause. Insufficient training in the transition practice in both adult and pediatric, lack of a devoted time of a transition preparation and process, and lack of assistance by pediatric generalists, and lack of available adult subspecialties. So still a human resource issue. What about the other side of the world, which is Asia? And this has been just only recently looked at. There is no published experience from Asia. In 2010, less than 10% of patients with chronic illnesses had ever received any transition information. And they looked at the barriers in that paper, and this is over three major reasons, which is lack of awareness of the importance of transition among both an adult and pediatric practicing rheumatologists, the variability of healthcare systems, and the cultural differences in parenting styles and family involvement in Asian families, which is more or less similar to us in the Middle East and Arab countries, in which the adolescents and young adults, they continue to live with their families, being supported with their families until they reach even full adulthood. And there is a major involvement and support, and even in the decision-making being influenced by adults, even among young adults. Therefore, they recommended and import for any transition care guidelines in Asia, it should include family management support that focus on augmenting parents' perception of their children and chronic diseases, as well as supporting their young children for autonomy and independence. What is KSA local experience? We did what they call it questionnaire about attitude of rheumatology practitioner among our 189 adult and pediatric rheumatologists using the QWART questionnaire, and almost 53% of the responders were from the pediatric group and 47% were from the adults, and 80% were governmental hospital practice physicians. And 88% of the responders agreed that age is the major factor for initiating the transition, which is supposed to be the 14, followed by the stability of the disease. However, interestingly, 23% believe that even if they grow up as a young adult, they need to be continued with the pediatric rheumatologist. So 68%, they looked at the age as a major factor, followed by stability of the disease. And there should be a form of a communication between the pediatric rheumatologist as well as the adult rheumatologist, at least to have a referral letter is considered to be a suitable method of communication. And the majority believe that parents are an integral part of any transition program. The very important component that is stressed in both adults and pediatric is education for the adolescents about their independence, drug adherence, and dealing with fatigue and coping skills. What is the major transition barriers considered to be is the unavailability of a coordinator system or policy, insufficient support from adult rheumatology team, limited clinic time and space in both adult and pediatric, and in almost 50%, they claim that lack of funding or financial compensation is considered to be an issue. So what do we have as a local transition experience at our center in Cache? We have a special adolescent rheumatology clinic where we look after children between the age of 12 up to the age even of 21. And in this very peculiar adolescent rheumatology clinic, we managed to transit and transfer almost 60 cases of GIA. At least 15 of them are still active, and almost 25 lupus patients and 3 vasculitis patients. Eventually, all of them, they have a very good disease control and no loss of follow-up. For the educational and vocational outcome, at least 10 of them didn't complete a higher education. We identified risky behavior very early with a proper intervention, and drug adherence and poor self-image were found to be the most encountered problem. What is our major challenges in this clinic is a coordination support, absence of a transition policy that we are still working on, and a systematic outcome assessment. We found that success of this journey is very linked to parental supportive management and education of the child for child independence and self-autonomy. And we highly advocate an early start of this process as early as 12 and 13, and it has to be individually based and depends on the psychological maturity. So what is the key elements that I close with for any transition successful program is that it has to be systematic, and it should be supported with guidelines and policy outlining the transition process. Early preparation with emphasis on education of transition and empowerment for self-management, promoting independence, communication, and engagement with health providers. And individualized the transition program has to be developmentally appropriate. Not all the patients are the same. Not all of them, they reach to an equal maturity. Even if they reach to the physical maturity, psychological maturity usually lags behind. And introduction to adult healthcare system and proper transfer through shared clinic or a designated transition coordinator. It's very important to provide the follow-up of those patients with an evaluation of the outcome of the transition process to identify barriers and improve outcome. So by this I conclude, and if I can take 2 minutes to show. This is a message from one of my patients, ex-patients, that is being sent to you, so it will take 2 minutes.
اسمي غادة الهزاع وعمري الآن 24 عاما. تشخصت بمرض الروماتيزم من سنة 6 سنوات. كنت صغيرة عندما ظهرت علي أعراض المرض. مرت السنوات وأنا الآن بخير ولله الحمد. سأروي لكم أصعب فترة حرجة. كنت تقريبا بين سن 13 و14 عاما فترة ما عرفت بإصابتي بمرض داء السكري. كان صعبا علي جدا حينما تلقيت هذا الخبر، وبفترة بسيطة تلقيت خبر أنني أصبت بمرض الغدة الدرقية. صعب جدا التمكن من داء السكري. انقلبت حياتي ما بين ما يناسب علاج الروماتيزم وداء السكري، وبفضل الله تعالى لقيت ما يناسبني من داء السكري والروماتيزم. وفي أواخر سنة 14 عاما تلقيت خبرا محزنا جدا، كوني الآن كبرت ولست طفلة وسأصبح بعيادة الكبار. كان خبرا صادما وموترا، كوني سأنتقل إلى دكتور آخر لم أعرفه ولم يسبق علي التعرف عليه. كانت فترة حرجة وصعبة جدا نفسيا وجسديا. أتذكر حينما مررت بفترة صعبة جدا هي حينما كان من حولي ليس مثلي أو ليس كغادة، يأكلون أدوية وكل شهر يتلقون العلاج، ومع كل وجبة أنسولين. قررت حينها أن أترك كل العلاجات التي أستخدمها. حسست بالتعب وشعرت أنني يجب أن أخذ هذا القرار، رغم أن هنالك كان دعما من قبل أهلي ودكتورتي وكانوا معي، لكن لا أعلم هكذا انتابني شعور أنني سأوقف كل شيء. لم أعلم ما أريده تماما، لكن كنت متعبة جدا. لو كان هنالك دعم من قبل مجموعة من الأصحاب المصابين نفسي لما أحسست نفسي بالتعب هكذا. لو كان هنالك أصحاب أحاكيهم ويحاكوني ويقولون لي معاناتهم وأقول لهم لما حسست بهذا الشعور. قويت نفسي بنفسي، لكن كان صعبا جدا. أختم كلامي بأن تمهدوا لنا طريقة انتقالنا من طبيب الأطفال الكبار لكي لا أصبح صعبا جدا على الآخرين تقبل هذا الخبر المحزن. وأيضا لو كان هنالك كل شهر أو أسبوع مجموعة لدعم المرضى يجلسون مع بعضهم البعض ويتكلمون عن معاناتهم لما كانوا حسوا كما أحسست أنا غادة هزاع. في الختام أنا بخير ولله الحمد. أخبرتكم جزءا بسيطا من قصتي وأصعب ما مررت به. الآن أصبحت خريجة الأدب الإنجليزي بجامعة حفظ الباطن ولله الحمد. وفي الأخير قال الله تعالى: لا يكلف الله نفسا إلا وسعها. دمتم بخير وبصحة وعافية. أستودعكم الله.
So by this, I just conclude with Ghada's story, who gave me the permission to share with you her story. And we have anyone in the pediatric rheumatology practice, they do have similar story in many of their patients. So thank you very much, and by this I conclude.